Does PMOS make weight loss harder?
It is the third most common endocrine condition occurring among women, and it is increasing. Losing weight is a very critical component. In any metabolic disorder, lifestyle is supreme.
Can women who are slim or not overweight also have the PMOS problem?
Absolutely. And I think it's very important that we recognize this problem. Doing the appropriate exercise, doing the mental relaxation and sleeping adequately, doing digital detox. Digital detox is very important.
So many doctors and patients resist for starting an insulin.
Insulin is more than 100 years old. It's a life-saving agent. It is the most potent anti-diabetic agent. Insulin is like a coolie. It picks up the glucose from the blood and puts it inside the cell. And we need glucose for every cell for energy. So we should never fear insulin.
GLP-1 drug can be taken by those who are not diabetic, but they only want to take for obesity.
You just can't say that I'm taking an injection, I can forget lifestyle. Exercise and strength training and muscle building is as important.
Hello and welcome to Lilavati Hospital's official health podcast series, where we bring evidence-based conversation with India's leading medical expert, where it helps people to take informed health decisions. I am Vitesh Damani from Lilavati Hospital. On behalf of Lilavati Hospital, I would like to welcome all our viewers, and today we are going to discuss about topics like PMOS, diabetes and weight loss medication. So for that, we are very privileged to have with us Dr. Shashank Joshi, one of the India's leading endocrinologists, and as he don't need any introduction, Padma Shri awardee and founder, vice president of PCOS Society. Very warm welcome, sir.
Namaste.
Now, today there is too much of discussion about PCOS and PMOS. So why this term has been changed from PCOS to PMOS, and is this more than just ovarian cyst?
So I think Hitesh bhai, first of all, I'm grateful to Lilavati Hospital and you for putting the focus on PMOS, the new buzzword for the old term called PCOS. And globally, people living with PMOS or PCOS and doctors treating them, they all came together, and for the last 14 years, this dialogue and discussion is going across global societies. And they decided to re-christen the name as PMOS, Polyendocrine Metabolic Ovarian Syndrome. They wanted to destigmatize it because there are a lot of people who have excess male hormone, women, it's a woman disorder, and they have a little bit of androgen excess, but they have normal ovaries completely. So it was not fair to people or women who are living with that. Second reason they changed the name is that ovarian cyst gives a very anatomical distinction. It doesn't tell us that, it gives you that you are having some abnormality, mere serious abnormality, anatomical defect. So the whole idea of making this term change is to destigmatize and make it scientifically more accurate. So I think the reason for the change, the nomenclature change was published in the Lancet. We have an Indian author, Dr. Madhuri Patil, who's my co-vice president of the PCOS Society. We'll have to change our name also. And in one and a half year, even the WHO and ICD will have a code for it. So now the new term is PMOS. Polyendocrine means multiple hormones. Okay, metabolic because there's a lot of, it's like diabetes of the ovaries, but insulin resistance across the whole body. Then of course, ovary is still the center space. And it's a syndrome because there are different subtypes of the phenotypes. So I think the change is a welcome change, but the change was mandated mainly to destigmatize it and make the term more scientifically correct.
Thank you, sir. It was a very insightful information on this topic, and this will, make me to move up to my next question. That is, does PMOS make weight loss harder even with diet and exercise?
So I think with women who are living with PMOS, there are two subtypes. There are people, normal women with normal weight, lean, that is low weight, and most people have a little extra body fat. So in the good old days, people used to call fatty liver. That term got changed now to MSLD. Similarly, people used to call fatty ovary or diabetes of the ovary, and that term is now called PMOS. If you do lifestyle is supreme. Okay, in any metabolic disorder, lifestyle is supreme. So eating less, eating on time, eating slowly, okay, doing physical activity, doing yoga and pranayam, doing kapalbhati, doing some good strength training exercises. And with that, if you eat appropriately, portion control, eat less, have protein first, and then sleep for 7 hours, it's a holistic lifestyle index. But people who are lean, people who are normal weight, as well as people who have PCOS, sometimes due to insulin resistance, it becomes tough to lose weight. And then we have to resort to medications. But remember, lifestyle still has its center space in the entire spectrum of PMOS. But unfortunately, in PMOS, we have, a facial hair, we have androgen excess and acne. So there are a lot of cosmetic issues, and then the girls have image issues. So it's very important that we correct the basic underlying metabolic defect. And in that, fat loss as well as losing weight is a very critical component. And so we have to look beyond lifestyle.
I think this is a very important message for our viewers. Sir has also mentioned about the insulin resistance. So doctor, we hear the term insulin resistance a lot. Why is it and why it is important for PMOS? And whether it affects fertility, pregnancy outcomes and hormonal balance in both women and men?
So insulin resistance is basically the modern type 2 diabetes. It's a lifestyle disease. So what is the function of insulin? Our pancreas, which is a small little organ behind our stomach, it has an exocrine component which makes pancreatic juice and which digests food. Then it also has the various cells like the alpha cell, the beta cell, the delta cell. The beta cell makes insulin. Insulin is like a coolie. It picks up the glucose from the blood and puts it inside the cell. By opening it, it's like a lock and key. So it is the key to open so that the glucose can go inside the cell. And we need glucose for every cell for energy. So it is like opening the key to that. What happens in insulin resistance? This key is either defective or the key is blocked. Like now rainy season will come, our doors will get clogged. Similarly, our cells get clogged. And when the cells get clogged, you get insulin resistance. When that happens at an ovary, then there is a hormone imbalance, male-female hormone imbalance. Remember, all men will have some female hormone. All women will have some male hormone. And what happens with PCOS is when the ovaries don't function correctly, they don't work properly, then they don't make adequate female hormone and there is a male-female hormone imbalance. And that term has been called androgen excess, which means male hormone excess. And that leads to a little bit of hair fall, a little bit of facial hair, a little bit of acne, and a lot of cosmetic symptoms. So that's called androgen excess. And that is why you get all the syndrome of PMOS or PCOS, what was formerly called. And it's very, very important to recognize this because this is how it starts. So insulin resistance of the ovaries is PMOS. Insulin resistance of the liver is MAFLD. So it's nothing but insulin resistance. This also occurs in men. And also there is a male equivalent of PMOS. But that is very rare and exotic. Some people feel people who are bald, they may have male variant of PMOS. But that is an ill-studied entity. Whenever we talk of the term PMOS or the old PCOS, we have to restrict it to women. It is the third most common endocrine condition occurring among women. First being diabetes, second being thyroid, and third being PMOS. And it is increasing. What is important, why this definition was also changed? Because it is across the woman's lifespan. It is not just, as you rightly said, that some people who cannot ovulate properly, they don't get periods on time, then when they get married, they cannot get pregnant. And then they have to go to infertility specialist. And once we give them treatment for infertility, they have a baby. The PMOS doesn't stop there. So it's not a cosmetic issue of acne and hirsutism. It's not an issue for pregnancy and infertility, but it goes beyond that. Even after 40 and 50, they can get cardiac diseases, metabolic diseases, type 2 diabetes. So it is a very comprehensive disease across lifespan. And therefore the name change is important. But yes, in PMOS, you get the ovaries the ovulation doesn't occur on time. Or sometimes they don't ovulate at all. And then they skip a period. So we have to give female hormone treatment for that. And that is called anovulation or oligoovulation. That means the ovum is released sometimes once in 2 months or once in 3 months. And therefore then a gynecologist and an endocrinologist and multiple specialists will get together and ensure that everything is appropriated. And then they get the cycles on time. And then we also have to sometimes look for fertility experts.
Thank you, sir. And I think, the message was explained very, in a very simplified manner. And sir, this will bring to me my next question where, this is very trending also, where can women who are slim or not overweight also have the PMOS problem?
Yes, it's a very good question, Mr. Damania, that this lean variant of PMOS or PCOS is also very common. and they are as insulin resistant as the obese variant. And therefore, it's very important to understand that women living with lean PCOS also have acne, hirsutism, hair fall, androgen excess, and all the manifestations which are there. So, just losing weight is not sufficient sometimes. Sometimes you may have a phenotype which may be lean, and correcting that underlying defect is the key. Therefore, appropriating the right diet, reducing the carb and fat load, doing the appropriate exercise, doing the mental relaxation and sleeping adequately, doing digital detox. Digital detox is very important in modern young children, adolescents. Because remember, PCOS occurs in adolescent girls. When they are breaking through puberty, that's the time it comes out. And usually we finish it after pregnancy is what people felt. But actually it's a disease throughout the lifespan. And therefore it's very, very important question you asked. And I think it's very important that we recognize this problem.
So can PMOS increase future risk of diabetes, fatty liver and heart problems?
Absolutely. I think you hit the nail, Vinkit. Because after 30, 35, 40, when the woman has achieved her motherhood and she has finished her planning of the family, then, she ignores her health. And women are superwoman because they have to do triple tasking. They have to take care of their children, they have to take care of their husband, they have to take care of their parents or their in-laws. And then they are also working. And then they tend to gain weight. Then they land up with a little bit of liver fat, which is MFLD. They sometimes land up with type 2 diabetes, and when they land up sometimes with heart disease. And they are protected by estrogen till the menopause doesn't set in. So when menopause occurs and the period stops, the estrogen protection is gone. And then suddenly after 45, 50, when menopause is achieved, they get the risk of developing heart disease, blood pressure, type 2 diabetes, MFLD, and sometimes even strokes and dementia. So it's very, very important that women should take care of themselves. It is not that we only looked at PCOS when they were young, they wanted to look beautiful, or when they were getting married or got married and wanted to have children, but they have to continuously look after themselves in terms of their lifestyle so that they don't get these adverse consequences or the deleterious consequences of PMOS, like, as you said, the liver fat or the heart disease or the blood pressure or the diabetes.
When should a newly diagnosed type 2 diabetes patient has to start with the insulin, and why do so many doctors and patients resist for starting an insulin?
It's a very good question. That people living with diabetes, when we tell them to take insulin, they feel insulin is like a last resort. But remember, insulin is what controls your whole body's metabolism. And therefore, some people who are born with type 1 diabetes or sometimes get type 1 diabetes due to autoimmunity. That means the beta cell factory is shut. And then you have to take insulin for life. That is type 1 diabetes. The other type of diabetes is secondary diabetes. That means the pancreas has been removed, or there has been a damage to pancreas due to pancreatitis or pancreatic diseases. That is the secondary diabetes. Or women who get pregnant during pregnancy, that is gestational diabetes. All these three categories need insulin because insulin is more than 100 years old. It is the oldest living agent on planet Earth for treatment of diabetes. It lowers glucose after diet and exercise. So we should never fear insulin. Unfortunately, 95-99% of diabetes which we see is type 2 diabetes, where there is insulin resistance. But remember, after 10 years, 15 years, 20 years, our pancreatic cells and beta cells are overworking. So they get exhausted or tired. And then they stop their ability to make insulin. And the C-peptide level comes down. And then we have to often resort to giving them insulin. So I think two things you should recognize: that you should ask your doctor or an endocrinologist to ensure that the insulin is being made or not being made. If there is no insulin being made in the body, or if there are some serious consequences like you have to go for a surgery or you want to get your sugar under control for any other reason, there is acute illness, then often we give insulin. Insulin is more than 100 years old. It's a life-saving agent. It is the most potent anti-diabetic agent. And it lowers glucose. It is the most strong agent, but it can cause low sugar attack. It can cause weight gain. So people have that fear. Don't have that fear. Insulin is what our portal vein has, what our body makes. So it is the most natural substance. Unfortunately, we can't take a tablet of insulin because the acid in the stomach will dissolve it. And that is why we have to give it as an injection. 5 Nobel Prizes have been won on insulin discovery, and never fear insulin. So remember, those who need it and particularly women with pregnancy who need it should take insulin, and they should always take it under monitoring. So you have to monitor the sugar. We have technology now. We can do a patch for glucose checking, or we can do the glucose checking in the meter, and then with a proper diet, proper exercise, proper monitoring, you can take insulin properly.
So a very important message for all the viewers, where sir has explained about to take insulin as early as possible when diabetes is detected, and also even patient can also use different techniques to monitor the sugar. So doctor, now there is too much of discussion on GLP-1 drugs also. So are GLP-1 drug a permanent treatment or a tool to treat diabetes and weight loss? And if yes, then what is the eligibility criteria for starting these medications?
So I think, one thing we should know, that when we cross the millennium, the children who are born were called millennials. Then came the Gen Zs. Then now we have the alphas. But the children who will be born now will be called in the GLP-1 generation. So GLP-1 is opposite of insulin. Our alpha cell makes a peptide called glucagon. And it was discovered by accident 25 years back. In South America, there is a South American lizard called Heloderma suscepticum. From the salivary secretions of that Heloderma suscepticum, there was a discovery of the GLP-1 exendin. And that actually lowered sugar, lowered weight, but did not cause low sugar attacks. So this was very attractive. Now most people initially used it for diabetes, but later on we discovered, and the peptides synthesis, peptide chemistry companies in Scandinavia and Denmark, companies in America, they did all the protein chemists and peptide biologists. They made very good compounds which we could give once a day or once a week, in which we could actually make people lose weight, they could lower their glucose, and they could also stay healthy. And therefore these GLP-1 drugs are here to stay. We have very good once a week agents which are approved by Indian FDA and US FDA under medical supervision of an endocrinologist or a cardiologist or a physician. And these are either called semaglutide or liraglutide or tirzepatide. So the liraglutide is every day, semaglutide is once a week, and this is a single agent. While the tirzepatide is a double agent, which is GLP-1 with GIP. And these agents are here to stay because they cause weight loss, they cause lowering of glucose, and they don't cause low sugar attacks. But they can cause nausea, vomiting, they can cause a little bit of diarrhea, constipation, they can cause abdominal pain or diabetic gastroparesis, and they have to be given after an endocrinologist supervises them. So a neck sonogram, abdominal sonogram, gallstones have to be eradicated. So we have to do it under supervision. These are not cosmetic drugs. They are strictly supervised medical drugs by endocrinologists. And if your BMI is about 27 with comorbidities or about 30 without comorbidities, then you may need to be eligible on these agents. So not everybody needs a GLP-1. There are specified criteria by our drug controller, and under supervision of a expert doctor like an endocrinologist, cardiologist, or a physician, you can take these agents. And if taken, they are life-saving and organ-protecting. Because our whole idea of people living with diabetes or people living with obesity is to make them free from complications. And these agents have some data to show that they are very protective in nature.
So what I want to understand, sir, which you mentioned that for GLP-1 also, along with treating diabetes, they also reduce weight also. So even, this medication can be taken by those who are not diabetic, but they only want to take for obesity. So it is possible, sir?
Absolutely. It's a very good question you're asking. A lot, and it's approved now for obesity. Okay, so people living with obesity can take these medicines under medical supervision, but it has to be appropriated with lifestyle. You just can't say that I'm taking an injection, I can forget lifestyle. Because you have to drink a good 2-3 liters of water, you need to consume adequate fiber, you need to take care of your gut health, you need to ensure that you are continuously being supervised. But yes, people who don't have diabetes can take these agents for weight loss if their BMI is about 30. And these agents have shown some very compelling data, and they are approved for obesity, as I said, under medical supervision. And they have documented that the newer and newer agents are coming. There's a triple agent which is coming in, and that triple agent will cause almost 25% weight loss. So on an average, most of these agents are causing weight loss between 10 to 15% of the body weight. But the newer agents may cause even up to 25% of weight loss, which is equal to bariatric surgery. So that is also there. But we should be mindful of one thing, I was talking about side effects. When we lose fat, we also lose muscle mass. So when you are taking these agents, apart from taking water, taking fiber, being supervised, we must do strength training exercises and ensure that we get adequate proteins on board so that we are able to sustain that weight loss long term.
Right, sir. This is a very important message for all the viewers where they have some misconception where they can use this drug only for weight loss, but sir has rightly mentioned that along with this medication, a lifestyle modification is required. So that has to one has to taken care of. Now this weight loss medication are based on Western studies like ADA and AAC guidelines. So how relevant are this result for the Indian patient? Because we Indian population has carbohydrate diet and their Western countries has more of protein rich diet.
Some of us were discoverer of the Asian Indian phenotype. In fact, I am one of them. So we are thin fat Indians. So we are thin from outside and fat from inside. It's called TOFI. And this is a very typical Indian paradox. In India, there used to be sukha, famine. So our ancestrally, we started storing fat in our abdomen. So we are born with more fat and therefore we are lean. So our BMI criteria is lower. So we cannot directly adopt a ADA or EAS guideline to India, but we can modulate it. And what is the modulation? The cutoffs of BMI have to be criteria. The body fat composition has to be looked into. And if you see the new ACE algorithm, they have said for Asian Indians, the BMIs are lower and we need to look at waist to height ratio, waist to waist circumference, which is as important as just the BMI. So the complication centric model and a very large comprehensive model has to be adopted. We just don't look at BMI, body mass index for weight loss. We also look at waist to height ratio, waist kinetic, body fat composition, and we can even measure it. Now, body fat also can be measured by different methods. For example, at our Lilavati hospital, we have a very good DEXA machine, which measures bone density. The same machine also measures body fat, because what we can get in that is, our body is made up of bones, which we do the bone mineral density, water, fat, and muscle. And by that DEXA machine, we can actually know what is your muscle to fat ratio. Okay, and we can actually measure it. And then after you give this agent, how much muscle is lost, how much fat is lost, we can measure it and do a better job. So this medicine, modern obesity management is about body composition management. And I think we have techniques, tools, and everything is available in India now. And at our hospital, we are able to give a comprehensive solution for that we can give you lifestyle advice, which is supreme. You cannot bypass lifestyle advice. We have facilities of all the modern techniques to measure your body composition analysis. And then we can give you solutions, which are treatment solutions, like drugs or surgical options in severe cases also. So we have all the options available, and it also needs counseling, it needs behavioral therapists, it needs dietitians. So it's a multidisciplinary approach. When we are making someone living with obesity lose weight, it has to be a multidisciplinary approach. And remember, health gains are not just about health outcomes. They're also about happiness outcomes, because a lot of people who are living with obesity, they feel distressed, they feel anxious, they feel very uncomfortable. So it's about their image. So we have to also counsel them and ensure that they are happy and healthy both.
Right. So sir, very insightful information and very simplified information for all our viewers. So sir, what happens when someone stops taking this medication? So after that, what are the consequences for them?
So I think we have to sometimes de-escalate the medicines. These medicines, though by definition are supposed to be for life, you have to ensure that under your medical supervision, you de-escalate them. And which is why lifestyle cannot be circumvented. This is not a quick fix that I take an injection, stop eating and don't exercise. Okay, exercise and strength training and muscle building is as important. Modifying diet and making adequate water, hydration and fiber is as important as taking this medicine. So if you are having adequate fiber on board, adequate water on board, adequate micronutrient and protein supplementation on board, adequate strength training exercises, then we can wean off these medicines also. You cannot give these medicines for life. And we can definitely, one thing is there that after 1 or 2 years, there is some regain. But there is some gain also. So I think one thing is very clear cut, that lifestyle is still supreme. And lifestyle will always remain supreme. And even if we have medicines and even if we stop them, lifestyle will ensure that it is retained. And exercise, lifestyle made diet, and sleep. Sleep is equally important. See, remember, people who are living with obesity, they often have sleep apnea. So we should do them a sleep study. Sometimes they need a CPAP. Again, at Lilavati, we have all the facilities of sleep studies, sleep labs, sleep experts. So they are all here under one roof. So we need to recognize one thing, that we have to be mindful of this entire process. And we can ensure that when you stop the medicine, diet, fiber rich, protein rich, meal replacement, eating slowly, then ensuring drinking adequate water, then ensuring you do strength training exercises, sleeping appropriately. If you have a CPAP, if there's a sleep apnea, under an expert sleep supervision, all this form a consortium of your entire program of the weight de-escalation of therapy. So de-escalation is also possible.
You had talked about the exercise and diet and all, and about the lifestyle modification. So intermittent fasting, which have become extremely popular in India. So now, as an endocrinologist, what is your clinical view? Is it safe for diabetics?
So there are a lot of fad diets, okay, and there could, every person on earth tries to have his own diet. You can have Dr. Joshi diet and Dr. Panikar diet and Dr. Damania diet, and everybody can have their own diets. So there is some biological basis. So as I said, we always fast and feast. India is a fasting and feasting country. There are religious fastings. There are fastings in Hindu religion, in Jain religion, in Catholics, they have the Lent. In our Mohammedan brothers, we have the Ramadan. So some of them are structured, some of them are not structured. Intermittent fasting is one such technique of time-restricted eating. And when we do this time-restricted eating, that is a scientific term for it. Okay, occasionally you may get health gains in terms of glucose control, lipid control, or weight control. But it is not a standard of care. Okay, it is not a standard of care. In select situations, you may get short-term weight loss, but it's not a lifetime solution. So, like the keto diets and so many other new diets which have come in, they may be appropriate for a select group of subset of population, but it's not a universal prescription. Also, there can be negative effects also. For example, there was a paper which was published 2-3 years back in the American Heart Association, where they had linked intermittent fasting to, say, heart disease. So we keep on, the last word on these feeding patterns and fasting patterns is not out. In fact, I have compiled a book on fasting because, as I said, there is religious fasting and there is time-restricted eating. And some of the time-restricted eating does cause weight loss. Let me be very honest about it. Does cause glucose lowering, but it has to be medically supervised. And it is not a standard of care. So it's not a routine recommendation. The routine recommendation has to be customized and individualized. And we have now gadgets to measure it. We can measure your glucose, we can measure your activity, we can measure your dietary calories, we can input them, and then we can get advice on them. So my advice is that this is not a blanket solution. It needs a lot of medical supervision, and please avoid crazy diets and some of these plans which may not be conducive to your body. So always discuss it with your endocrinologist before you go into any of these. And also sometimes when you do these drastic diet patterns, you need to consult a cardiologist and get a green signal from a cardiologist, because they may unmask a latent heart disease also.
Thank you for your insightful information, and I think it is a very important message for our viewers also regarding this exercise prescription for diabetic patient, walking versus strength training versus yoga. What does the evidence actually say for Indian patients specifically?
So the traditional teaching was 30 minutes of physical activity 3 times a day, 3 times a week. Okay. But when we did the Indian physical activity recommendations, I'm also one of the authors with Dr. Anup Mishra from Delhi, we decided to do 60 minutes daily exercise for Indians. Because we are thin fat Indians. We have something called sarcopenia. Sarcos is muscle, penia means less muscle. So we need to build muscle strength. So out of the 60 minutes, 20 minutes should be aerobic exercises. 20 minutes should be muscle strengthening exercises, okay, where you are building the muscles, your abdominal muscles, your hand muscles, leg muscles. And then 20 minutes you should be fidgety. It's called NEAT, non-exercise activity thermogenesis. So I think when we are looking at this, it has to be holistic. And there's no point exercising and keep being anxious and stressful. So yoga is silent in yoga. I work in this. We have the World Yoga Day coming up very soon under the guidance of our Honorable Prime Minister Narendra Modi ji. And very clearly, yoga has 9 components to it. First is the processes of cleaning, which is nothing but the kriyas like neti or dhavti. Then you have the posture, which is asanas, which are muscle strengthening asanas, where then you have pranayama, which is breathing exercises. Then you have dhyana. So there are different parts of yoga. So yoga also has a role in prescription of a exercise plan. And if you see the latest American Diabetic Association, European Association Study Diabetes exercise recommendations, they have incorporated yoga, they have incorporated strength training, they have incorporated aerobic activity and need, but they have also incorporated sleep. And they have said that you should sleep on time, you should sleep for minimum 5 hours, not more than 10 hours. You should not be a Kumbhakarna. 7 hours is the ideal sleep. You should sleep, and there are 2 types. There are late nighters and early risers. So they feel the early risers have a better sugar outcome. So from a diabetic standpoint, sleep is important. In exercise, aerobic, muscle strengthening exercises are equally important. Being fidgety is equally important. And we have a lot of new data to show that exercise can give you happiness. Okay, so it reduces anxiety. For example, we have published studies now where we do mantra chanting and your anxiety levels can come down with it. Because a lot of our people are anxious. So I think there is a lot of sense that exercise is not just for weight loss, it is for weight maintenance, it is for lowering glucose, but it's also to make you calmer, more happier, and sleep well, and you can smile better. So I think overall, exercise has a very big holistic role in not only diabetes or obesity, but overall for life also.
So very insightful information for all the viewers. What has to be done in the exercise, specifically holistic approach is required when you exercise. So before closing this, sir, what is your final comment on the topics like PMOS, diabetes and weight loss medication?
So for PMOS, I think as Charles Dickens said, you are born in best of times but worst of times. We are born in best of times because we have information overload. So don't get cluttered by the term. Okay, your image is important, fat loss is important, supervision is important, cosmetic outcomes are as important as pregnancy and fertility outcomes. They are as important as cardiometabolic outcomes. So we have to be supervised, we have to stay happy, and we should be responsible. We should not be reckless. I think that is the most important thing for people, a woman living with PMOS. And as I said, there are a lot of new options available now. So whether you are an adolescent girl with acne and hirsutism, whether you have irregular periods and you are in your 20s, whether you are in your 30s and trying to plan a baby, or whether you are in your 50s after menopause having blood pressure or diabetes. And it's all a part of a common PMOS complex. And it all you can be healthy and happy with it. You can smile, you can ensure that you have a proper lifestyle prescription. And it's a part of the general NCD conundrum. So whether it's diabetes or obesity. So my take-home mantra is very simple. Okay, lifestyle is the key. So, eat slowly, eat on time, eat less, eat mindfully. Okay, at least try to do 8,000-10,000 steps a day. If you can do muscle strengthening exercises, do yoga, dhyana, meditation, and stay happy, that's great. At least sleep for a good 7 hours. Don't sleep less than 5 hours. Don't sleep more than 10 hours. If you're snoring, get a sleep study done. But doing all this is important. But if you're all the time going to be aggressive, anxious, grumpy, that's not important. You have to also smile. Remember, laughter is also medicine. So I think it's important that my take-home message and mantra is very simple. Eat less, eat slowly, eat on time, eat right. Try to do at least 8,000-10,000 steps or strength training exercises or yoga. Try to at least, sleep for a good 7 hours and always be smiling and happy.
Thank you, doctor. It was a very wonderful interaction and very informative session with you. I think many of our viewers, they have lot of doubts and confusion. So it will be clarified with this session. So on behalf of Lilavati Hospital, I would like to thank you for taking out your time and for this podcast discussion.
Thank you so much. Thank you. Jai.
And also on behalf of Lilavati Hospital, I would like to thank you all our audience who are viewing this podcast. And stay healthy, stay focused. Thank you.